اوكي دكتور جون، انا والدكتور خالد مسافرين حاضرين مؤتمر الديفورميتي في القاهره.
اوكي ثانك يو
اوكي فانا حفعلك ادمن، لانه حخش الورك شوب، ما بكونش موجود في الزوم. اوكي يا دكتور؟
اوكي ثانك يو.
اوكي دكتور، يلا يعطيك العافيه يا دكتور، وان شاء الله
الله
تكون محاضره
يعافيك.
ممتعه والشباب يحضرون ان شاء الله. يلا بالتوفيق يا دكتور. تمرنا بحاجه من القاهره؟
يلا لا ابدا ابدا.
يعطيك العافيه يا دكتور، الله
يلا
معك.
رح بلش.
اوكي استاذ.
You see my screen?
Yes, doctor. It's very clear.
You do? Okay. I just want to adjust ليه عم بيجي ليه هيك؟ ما بعرف ليه السكرين ما عم تيجي كلها. I have to share again. بدي ارجع فوت. ما عم تيجي السكرين كلها. هلا زبطت. Okay, is everything clear now? مين سمعني؟ بس مش نأكد انه عم تقشعوا السكرين. الو. Am I clear? Okay, now. Okay. The topic today is anything to do with sports resulting in injuries of the hand and wrist. Hand and wrist injuries in the athlete are frequently encountered by orthopedic surgeons. Although treatment of many of these injuries is effective, management of these injuries can present a challenge to the physician. So you have to always be aware of the principles of management. In understanding the diagnosis and treatment of common and hand and wrist injuries in the athlete, along with guidelines for return to play, will help the physician provide optimal care for a specific injury. So you have to keep this in mind. You have to stick to the principles. Now we will be talking about hand injuries that occur in sports.
لك الرابط بتبدأ ولا بدأت؟
بدأت. I started. They seen the screen. I'm calling out. They're not seeing the screen or not. I just want to know. عم تسمعوني يا جماعة؟ حدا يجاوب. خالد.
Okay, now I will see. I will show.
هذا عم بيحكي في حدا فينا نعرف. ايه بدي الصوت، بدي اعرف اذا حدا عم بيسمع.
دكتور جون
ايه
تفضل.
عم تسمعوني؟
اي واضح الصوت والصوره واضح.
فاذا رح برجع ببلش من هون. Okay. Not only are the hands used in almost every sport for sport-specific tasks, but they are also instinctively used to protect the body from the initial impact or fall with another person. So you have to take this into consideration. So the hand's function is for protection of the body and for use. It has two functions. Okay, keep this in mind as I'm talking this presentation. Hand injuries are common in athletes and occur in almost every sport played. Neglected injuries can have detrimental consequences. Therefore, it is important quickly to يا الله ليه هيك عم بيصير؟ ليه هيك؟ قطع هذا. يا الله.
السلايدات واضحه يا دكتور؟
هلا ماشي الحال. اوكي. يعني اليوم شيء مبيض وشي. طيب. Most injuries can be treated non-surgically in the general population, but athletes require special consideration. Metacarpal and phalangeal shaft fractures are the most common fractures and are frequently encountered in athletes. Most injuries can be treated non-surgically in the general population, but athletes require special consideration. When treating hand fractures, deformity follows under treatment. Stiffness follows over treatment. I repeat, when you're treating a fracture, if you're under treating it, it will lead to deformity. If you are over-treating it, leaving it in a cast or a splint for some time, you are over-treating it, and therefore deformity and stiffness follow poor treatment. This should be kept in mind. Distal phalanx fractures, tuft fractures. If you look at the X-ray on the side, it gives you the picture of a tuft fracture, a comminuted fracture, a crush fracture of the distal phalanx of the finger. These are the most common hand fractures and require only short periods of immobilization from 10 to 14 days. I put it in red. There are many specialists who keep them in a splint for 1 month. They end up with stiffness of the DIP joint. This should not be done. The nail bed should be inspected because this is a common associated injury. مش يعني نطلع بالفراكشر and forget about the nail bed. Substantial nail bed injuries require meticulous repair technique to avoid nail plate abnormalities. The nail bed, in my opinion, is more important than the fracture. More proximal fractures in the phalanges and metacarpal bones can usually be treated with approximately 3 weeks of immobilization, followed by early, I repeat, by early protected range of motion to prevent stiffness. I repeat, stiffness if minimal displacement and no rotational deformity exists. Early edema control along with motion and elevation should be incorporated into the therapy. Fractures of the metacarpal head are also rare intra-articular fractures, most commonly occurring in the index finger. Surgery with Kirschner wires or mini fragment plates and screws is required if more than 1 millimeter of intra-articular step off exists. These injuries are commonly associated with fight bites, which should be treated with appropriate irrigation and debridement and the course of antibiotics. Metacarpal neck fractures, which is boxer's fractures, they usually occur in the ring and little fingers, although other metacarpal bones can be involved. Lateral radiographs are necessary to evaluate the amount of angular deformity. 15 degrees of deformity can be tolerated in the index and middle finger metacarpals. 30 to 40 degrees in the ring finger and 50 to 60 degrees in the little finger. But one should not forget that if they have a high degree of the angulation, this would let the knuckle reset and the patient would be unhappy. It is preferable in these severe degrees to reduce this fracture by an elastic intramedullary pin. The interossei are the deforming forces that cause dorsal angulation. Don't forget this. We ask in questions, what about the interossei? Or what are the structures that deform the fracture and produce a dorsal angulation? and you should mention interossei. Traditionally, an ulnar gutter splint has been applied for 2 to 3 weeks, but data from 2007 showed no difference in disabilities of the arm, shoulder, and hand scores with body taping alone. And what I mean by body taping is when you tape the finger to the neighboring finger. This is meant for the junior staff. Malunion is common, and metacarpal neck fractures. This occurs, but is rarely a functional deficit in the athlete. In the rare circumstances, open reduction and internal fixation, closed reduction and percutaneous pinning, or an intramedullary technique can be considered if malunion is not tolerated. Keep in mind that malunion of metacarpal neck fractures is not well tolerated, especially in the third and fourth metacarpal, where you see that the knuckle is recessed in relation to the adjacent knuckle. Patients are not happy. In addition, the grip becomes weaker. So you have to keep this in mind, especially in tennis players that hold the racket. The grip of the racket becomes weaker. So you have to keep this in mind. So beware of fractures of the neck of the metacarpal for deformity, and not only for deformity. You should not forget an important problem: rotation. Rotation is very important. If you ask the patient to flex the fingers, all the fingers should point towards the tubercle of the scaphoid bone. You should also look at the nails to see the amount of rotation on the nails in relation to the adjacent nail. This would tell you about rotation. So you have the correct amount of rotation in all forms of fractures of the hand. You have to be aware of any significant recession of the knuckle. For metacarpal shaft fractures, less angular deformity is tolerated than for metacarpal neck fractures. 10 degrees for the index and middle fingers, and 30 degrees for the ring and little fingers are the maximum amount that can be tolerated. Malrotation is unacceptable because 5 degrees of malrotation results in 1.5 centimeters of digital overlap. The worst thing for you to have is when you get a metacarpal fracture, you treat it, you don't pay attention to the amount of rotation, and the patient comes to you and says, "Look, doc, my finger's overlapping over the neighboring finger, and I don't like it." And you have to tell him that he needs surgery. You have to tell him that he needs an osteotomy. You have to tell him that he has to repeat the treatment procedure over again. Shortening is acceptable up to 5 millimeters, but with shortening of the metacarpal, 7 degrees of extensor lag occurs with every 2 millimeters of shortening. So if you have 5 millimeters, you say it's acceptable, but they're weak. They have weakness. So you have to realize that with every degree of shortening, you have to realize that there is a 7-degree extensor equivalent to 2 millimeters of shortening. Don't forget this. Extension becomes weak. Open reduction and internal fixation is commonly performed in athletes with metacarpal shaft fractures if surgical criteria are met. But closed reduction of the phalanx or closed pinning of a fracture of the proximal phalanx can be considered. Don't forget this. There is a place for closed reduction and percutaneous pinning in these fractures. You can put two parallel pins at the proximal and distal fragment. Do your reduction and insert it into the neighboring metacarpal. It will maintain your reduction. Metacarpal base fractures are uncommon, usually stable, and minimally displaced. Displaced fractures at the base of the metacarpal can result in arthrosis, degenerative arthritis. The fourth and fifth carpal metacarpal fracture dislocations are known to be unstable injuries and require pinning of the carpal metacarpal joint. Many compare a fracture of the base of the carpal metacarpal joint of the fifth joint, similar to that which occurs with the Bennett's fracture. These are intra-articular fractures. They can be unstable, and as a result, you have to pin them. Fragment is flexed by the interossei. Don't forget this. We started the lecture with the interossei, and now we are talking about the interossei. They are part of the deforming force. They flex the proximal fragment. And the distal fragment, on the other hand, is extended by the central slit. Middle phalangeal shaft fractures can have volar or dorsal angulation, depending on the location of the fracture. Malrotation, as I've repeatedly mentioned, is unacceptable, and only 10 degrees of angulation in any plane is tolerable. So don't forget, malrotation is very important, and 10 degrees of angulation in any direction close reduction and percutaneous pinning can be considered by open reduction and internal fixation with a plate in the athlete may be a better option. Oblique spiral fractures can be treated with interfragmentary lag screws if the fracture line is twice the bone diameter. Coming to phalangeal head fractures, these are important fractures because they are difficult to treat, and if not treated well, they will end up with problems. They can be unicondylar or bicondylar. The collateral limb must be considered with displaced unstable fractures, usually with open reduction and internal fixation with interfragmentary screws. Athletes can return to play with appropriate protection after the fracture is stable and sport-specific range of motion is obtained. So fractures of the hand are important. We know that the hand protects the body, and we know that the hand is used for specific functions which are meticulous. For an athlete, a fractured hand is far more important than a common individual. Any fracture should be taken seriously. If you have a fracture of the tuft or distal phalanx, you should respect the nail, as this will result in a deformity. Any fracture of the phalanx, the proximal phalanx, the proximal fragment is displaced volarly. The distal fragment is displaced dorsally by the central slip. Fractures of the bases of metacarpals, especially the fourth and fifth, should be taken seriously. They are as important as fractures that occur in the first carpometacarpal joint, resulting in a Bennett's fracture. One should take these seriously, treat them according to rules, and always think of the patient and think of deformity, and preventing stiffness is one of the principles. Recent data have shown successful early return to play in less than 1 month after open reduction and internal fixation for metacarpal and phalangeal fractures with appropriate protection. To ensure adequate healing. Bennett fractures are intra-articular fractures that involve the base of the thumb and occur when an axial load is applied to the flexed and adducted thumb. This is the typical presentation of a Bennett's fracture. It's a base of the first metacarpal bone. It's an intra-articular fracture. A fragment remains with the adjacent metacarpal while the whole front metacarpal is displaced by the pull of the abductor and extensor pollicis brevis. All these act as deforming forces leading to the appearance of this fracture. So the abductor pollicis longus displaces the metacarpal base proximally, and the anterior oblique ligament pulls the Bennett fragment to the base of the second metacarpal. So it is the anterior oblique ligament that maintains the fragment in relation to the second metacarpal. I have to excuse myself for 1 minute only. عندي اجتماع عم بعطي محاضرة ليوروب. عندي 4 ساعات محاضرة عم بعطيها هلا. بليز إذا فيكم تبعتوا لي مسج بعدين بجاوبكم. أوكي الله خليكم. يلا باي باي. Okay, it's okay. And I'm speaking. I'm online now. Thank you. Sorry يا جماعة. Bennett fractures are surgical injuries and require close reduction, cutaneous pinning, or open reduction and internal fixation if the fragment is large enough. We should aim at a perfect reduction to prevent degenerative arthritis. In the athlete, it is very important to get a very good reduction. Why? Because this athlete uses his thumb, especially if he's a tennis player, for his function. So don't forget this. Extra-articular thumb metacarpal base fractures can tolerate up to 30 degrees of angulation as a result of carpometacarpal joint hypermobility. It's not intra-articular, it is extra-articular. Therefore, being that the thumb, if you look at it, you have abduction, adduction, flexion, extension in all motions. This will allow the individual to tolerate some degree of deformity. So don't forget it. The only benefit is the hypermobility that is making or compensating for the deformity. So in these cases, if you get a moderately good reduction, percutaneous pin fixation should be considered in high-level athletes for earlier rehabilitation and return to play. So the more specific the candidate is in sports, you should consider open or percutaneous fixation for this fracture and keep it in mind. What about finger dislocations? Dorsal dislocations of the proximal interphalangeal joint are the most common finger dislocations. Simple dislocations are usually reducible with hyperextension of the middle phalanx followed by distal translation. The volar plate can at times be a problem. It's a headache. It can block reduction. If stable after reduction, body taping, as is shown in the slide, and range of motion are initiated, is important in the management. If unstable, a dorsal blocking splint is applied, meaning the splint is applied on the dorsal surface of the joint. It prevents a recurrence of the dislocation. But the patient will be allowed to flex the finger, but he won't be allowed to extend or hyperextend the finger because it will end up with a dorsal dislocation again. Convulgent fractures of the volar plate should be monitored carefully because a flexion contraction can develop. Early return to play possible with body taping based comfort and stability after action. Location often involve fracture of the volar base of the middle phalanx. The Hastings classification summarizes these injuries. You should look it up, you should memorize it, and guides treatment, and is based on the size of the middle fragment. We have several types. We have type 1 fracture is less than 30% of the articular surface. Type 2 is fractures between 30 and 50% of the articular surface, and these are tenuous. Type 3 fractures have more than 50% of the articular involvement and are considered unstable. And if reducible, types 1 and 2 can be treated with a closed extension block splint, carefully decreasing the amount of flexion by 10 degrees every week. Let us speak about it. Let's speak about it. If you have a proximal interphalangeal fracture dislocation, which are stable and which are not. If it's 30% or less, it's considered stable. 30 to 50 is equivocal, it's tenuous. Keep this in mind. And depending on these, whether it's stable or unstable, will tell you whether you should operate or not. These are the fractures. Class 1 is an oblique volar fracture. Class 2 is a longitudinal sagittal fracture. Class 3 is a dorsal coronal fracture of the proximal interphalangeal joint. We don't like them so much. The long oblique fractures you can treat by putting screws 3 and 4. You have to somewhat put some form of fixation by percussion and some form of immobilization. Unstable fractures must be treated surgically using open reduction and internal fixation, or hemi-hamate arthroplasty, where a portion of the hamate is removed and inserted in its place in the form of a replacement. Chronic fracture dislocations are treated using volar plate arthroplasty or hemi-hamate arthroplasty. So you have to think this in mind. Pilon fractures of the base of the middle phalanx are treated using longitudinal traction, pin and rubber band traction, and immediate motion. Good results have been obtained using pin and rubber band traction. And this is a photograph showing of how you put transverse pins and build it up in such a way that you can apply a rubber band from both sides on the pins, and you will end up getting a continuous traction. This is very effective. So in other words, you put your pin first of all in your proximal phalanx at the distal end. You bend them. Then you put the transverse pin in the middle phalanx at a moderate distance between it and the first pin. So you bend the pins in the proximal pins in the proximal fragment, and you create a loop through which, when you apply traction, you will have a slot to move along the pins, and then you apply your rubber bands. So this is a technique that I have used for years, and it works beautifully, believe me. Even though you have a comminuted pilon fracture of one of the phalanges, it reduces it. At times I use this in association with pinning, percutaneous pinning. So the two together helped me a lot in these difficult fractures. Volar proximal interphalangeal dislocations are less common and are associated with central slip disruption. After reduction, the proximal interphalangeal joint should be splinted in extension for 6 weeks to prevent a boutonniere deformity and allow healing of the central slip. I repeat, you should immobilize them in extension for 6 weeks so that you can allow the central slip to heal. If it doesn't heal, the patient will develop a gradual botanier deformity, which is not agreeable to the patient and the family. If the dislocation is still unstable at reduction, pinning for 3 weeks is required. Rotatory subluxation dislocations of the proximal interphalangeal joints also can occur, leaving the central slip intact, but the condyle buttonholes through the central slip and lateral band. And these injuries often require surgical intervention for reduction. This is a radiograph showing a rotatory subluxation of the proximal interphalangeal joint. This is shown in the lateral view and the oblique view and the PA view. You can see that there is a buttonholing of the condyle of the middle phalanx into the capsule, and the central slip is displaced medially as a result, preventing it from undergoing reduction. What about the skier's thumb? Injury to the ulnar collateral ligament of the thumb at the metacarpophalangeal joint. Hitting them or using them as the whip, and the rabbit will sort of jump up as he's being hit, and this would injure the thumb, causing it to have a deformity. A deformity where the thumb at the carpometacarpal joint is displaced, not at the carpal, sorry, at the metacarpophalangeal joint, is displaced, causing it to tear the collateral ligament. So the competent ulnar collateral ligament is critical for effective pinch, and we know it. Now, as far as skiing, if you pay attention, these injuries are called skier's pole injuries, where the individual is skiing and suddenly his skiing pole gets attached within the snow and causes a force leading to a tear of the ulnar collateral ligament, secondary to the abduction force, with the pole being fixed within the snow. So let's see what happens. You have over here the ulnar collateral ligament. You have the first metacarpal. You have the first proximal phalanx. The ulnar collateral ligament avulses a fragment of bone from the base of the proximal phalanx of the thumb on the ulnar aspect. And this is known as a gamekeeper's thumb. So it is important to obtain radiographs before stressing the metacarpophalangeal joint to avoid displacing an otherwise non-displaced fracture. Physical examination is performed with a valgus stress applied to the thumb in both extension testing the accessory ligament, and in 30 degrees of flexion, testing the proper ligament. So you have to do it in extension and in flexion and see if it opens. And this would lead to this injury by being ruptured. This shows it further. Look at the ulnar collateral ligament of how it's torn. It can evolve with a fragment of bone, or it can tear, or this ligament might go and become angulated and fit, and it enters both heads of the adductor pollicis. As a result, this will prevent it from coming in line with the distal component. And so closed treatment is difficult. It won't heal. The underside of the joint should be palpated for a Steiner lesion. A Steiner lesion is, I said, when the ligament becomes interposed and it cannot be kept in line with the distal component. Both the proper and accessory ligaments are retracted and lie on the adductor aponeurosis. Keep in line this injury. This is quite a common injury to occur in athletes. So a Steiner lesion is when the proximal ligament retracts. So if you reduce the thumb to normal alignment, the torn ligament folds back on itself and is held there by the edge of the adductor tendon. So please don't forget this. This is the gamekeeper's thumb. The adductor aponeurosis interposition prevents direct ligament healing without surgery. More than 35 degrees of laxity alone, or more than 15 degrees of laxity compared with the contralateral side, is considered a positive test result. So you have to compare it with the opposite side. You should apply a valgus stress within reason and compare one side with the other. If it is more, then it tells you this is an injury and what should be done will be decided. Stress radiographs are useful for identifying a Steiner lesion, as are MRI and ultrasonography. Incomplete acute tears and non-displaced avulsion fractures are treated with a thumb spica cast for 4 weeks, followed by removable protective splinting for 3 more weeks with active range of motion exercise. Complete tears require open repair with suture anchors or bone tunnels placed at the site of the avulsion, which most commonly is the proximal phalanx. So keep this in mind. It's an easy injury to remember. The gamekeeper's thumb. You have to think of the avulsion of the collateral ligament. You have to think of how to examine the hand, compare a valgus stress of one hand with the other. You have to keep in mind that these ligaments, once torn, can retract and lie on the adductor pollicis tendon. And at times it can lie in between two, and this makes it difficult. You have to operate this patient, identify the ligament, and suture it by means of anchors to the proximal phalanx. This is how we apply the sutures, and the results are good. Although complete, minimally retracted tears can heal with non-surgical treatment, the tear will not heal in the setting of a spinal lesion because of the adductor aponeurosis and interposition. This prevents it, allowing it to have a line-to-line position to heal. Strenuous activity is avoided for 3 months following the treatment, with unrestricted return to sport, usually at 2 to 3 months. Recent data have reported good long-term outcomes following repair with 2 suture anchors in collegiate football players. Skill position players were repaired acutely. Linemen were able to complete the season with bracing or casting before undergoing repair of this injury. What about extensor tendon injuries? The mallet finger, it's a very common injury. We see them. The patient tells you, I was sticking out my hand to grab the ball, I missed the ball, and the ball hit the dorsal aspect of the distal finger, and suddenly there was a sudden flexion against an extension force, and suddenly my finger gave way, and now I have this flexed interphalangeal joint. I'm not happy because when I shake hands, it catches on individuals. Now, if it's acute, of course, you have to treat it. And this can be cases where you have avulsion of a fragment of the dorsum of the distal base of the phalanx, or you can have a rupture of the tendon. Mallet fingers, when the extensor tendon attachment to the distal phalanx becomes incompetent, resulting in inability to extend the distal phalanx. This can be either a soft tissue or bony avulsion, as I mentioned. The tendon may rupture within it, or the tendon is so that it can avulge a fragment of bone. Soft tissue mallets are treated with 6 to 8 weeks of extension. We used to include the PIP joint with it, or the proximal phalangeal joint. Nowadays, we found that it's not important. We only put the DIP in full extension with the volar splint. At times, we could put a pin with it in full extension, but we have to be very careful about the tip of the pin, because this can get infected and you'll be forced to remove it before time. A slight residual extensor lag of approximately 10 degrees should be expected after treatment. Don't be disappointed. This is a normal finding. They tend to lose 10 degrees of extension, no matter how good you treat the patient. A bony mallet should be assessed with lateral radiographs, both without external force and with the joint held in extension to assess if the fracture reduces adequately. Take a lateral X-ray. Take it in full extension. See where is the position of your fragment. This will tell you of how to treat the patient. Bony mallet injuries also are treated with 6 weeks of extension splinting. If the distal interphalangeal joint is subluxated or the fragment is large and results in substantial articular incongruity, open reduction or dorsal block pinning should be considered. Look at this method. This method is easy. If you have a fragment of bone, you put it through the tendon at the junction with the fragment, you tilt your pin distally, and then you insert your pin through the cortex, post-cortices, and keep it as such. This will reduce your avulsed fragment. Then you extend the finger and put your pin through the distal phalanx into the proximal phalanx. This will give you a good result. We have experienced this on several cases, and we are quite pleased with this technique. Chronic mallet fingers result in a swan neck deformities. This is very true. Why? Because the patient begins to hyperextend the proximal interphalangeal joint to compensate for the flexion that occurs in the distal interphalangeal joint. Recent data have shown good outcomes with splinting for soft tissue mallets that were treated within 6 weeks of the injury. So, if you're asked the question, what is a complication that occurs in a neglected distal mallet finger over time, you should mention that the lateral ligaments of the PIP joint will tend to sublux dorsally, and as a result, the PIP joint will be an extension. Previously, splinting at night for 1 month after cessation of full-time splinting has been performed, but recent data reported equivocal outcomes without night splinting. This is a boutonniere that occurs secondary to tears of the central slip. So you have to, if you're asked what is a boutonniere deformity, you tell them you have the central slip is avulsed by an injury. Let's say it's of the middle phalanx, yes. They have a triangular ligament attenuation. You have volar migration, as I mentioned, of the lateral bands. Now the lateral bands now flex the PIP joint and extend the DIP joint. So this is the mechanism in which a boutonniere develops. It's very easy. If you're asked in an exam and you're given a boutonniere deformity and you're told, how did this occur? The very first thing you say that when did this occur? Then you say the lateral bands are slipping from the lateral position to the volar position, and they're acting, instead of extension, flexion on the PIP joint. And as a result, they hyperextend the DIP joint. So keep this in mind, please. A boutonniere deformity is the result of a central slip, rupture, triangular ligament attenuation, and volar migration of the lateral bands. On examination, the PIP joint is passively placed in extension. If the patient can maintain the PIP joint extension, the triangular ligaments are likely intact and splinting usually provides a good outcome. This is to tell you whether you can do a conservative treatment on these patients. You ask the patient with the boutonniere deformity, you straighten the joint, you put it in extension, then you let go and see if it maintains its position. If it doesn't maintain its position, it tells you that the triangular ligaments are gone, the lateral ligaments are displaced distally, they are hyperextending the DIP joint and flexing the PIP joint. The Elson test is used to assess a central slip rupture. The proximal interphalangeal joint is flexed to 90 degrees and blocked while extension of the PIP joint is attempted. And the DIP is assessed, meaning the distal interphalangeal joint is assessed. So let us do this. The Elson test is a hand special test used to evaluate integrity of the central slit, the extensor hood rupture of the hand. The patient flexes the finger to 90 degrees at the proximal interphalangeal joint over the edge of the table. Just for okay, over the edge of the table. The patient is then asked to extend the PIP joint while the clinician palpates the middle phalanx. The absence of extension force at the PIP or proximal interphalangeal joint and fixed extension of the distal joint indicates complete rupture of the central slip, and this will give you a positive Elson test. Look this up, learn how to do it, and it will give you a lot of information of whether you're to do surgery or not on the patient and treat him conservatively. The test result for a central slip injury is positive if the DIP becomes rigid or actively extends to neutral. Radiographs may show an avulsion fracture. A closed acute boutonniere injury is treated with extension splinting of the PIP for 6 weeks, followed by 5 weeks of night splinting. Surgery is indicated if close treatment fails for open injuries, for large displaced avulsion fractures, or in the setting of an unstable volar proximal interphalangeal dislocation. This is such an example. You can see that there is a central slip avulsion, and this would lead with time to a boutonniere deformity. For large fracture fragments, open reduction and internal fixation can be performed, or the fragment can be excised and the tendon repaired with suture anchors. Now let us see. Over here we have a problem. Okay, sagittal band injuries is such. Look, I put this up because so that you would see what is happening. If you see that the central slip is torn, where I have the round curve, if this is the central slip is torn, these bands migrate distally, volarly. Instead of extending the PIP joint, they flex the middle phalanx. And as a result, a botonier deformity would result. If an extensor lag of the finger is present, laceration or rupture of the sagittal band should be considered, which results in ulnar subluxation of the extensor tendon. This is what I'm going to mention about. Once I had a obstetrician, he came to me, he said, I had sudden pain on the medial aspect of my proximal phalanx of the index finger. Then suddenly I realized that my finger is deviating to one side. Well, let's go back to the previous. These bands can be ruptured, and these tendons are supported by a balance between both sides. When one ruptures, the whole tendon will pull towards the opposite side against the absence of tension of the one that had ruptured, and it will cause the finger to deviate. This is an injury that occurs. If an extensor lag of the finger is present, laceration or rupture of the sagittal band should be considered, which results in ulnar subluxation of the extensor tendon. So the lateral bands, these rupture, lacerations, or by means of trauma, external trauma, this would cause an imbalance. As a result, the whole tendon will go into ulnar deviation or radial deviation, depending on which side is ruptured. This injury, also known as boxer's knuckle, also can be associated with a capsular injury of the metacarpophalangeal joint and middle of the middle finger, and is the most commonly affected. So it's most common with this. On examination, the patient is unable to initiate metacarpal joint extension, but can maintain extension after passive finger extension. The extensor tendon dislocates to the contralateral side when the metacarpophalangeal joint is flexed and reduces when the joint is extended. So the boxer's knuckle occurs when you have a rupture. I'm going to go back. When you have a rupture of the sagittal band from one side, and as a result, it can leave the finger in extension due to the intact side, or on the other hand, it can lead to a deviation of the finger towards the side which is not ruptured. Keep this in mind, okay? It's called the boxer's knuckle. Okay. The mainstay of treatment of acute injuries in the general population is a flexion block, splinting the metacarpophalangeal joint for 3 weeks. But in athletes, surgical repair must be considered depending on when in the season the injury occurs and the athlete's preferences. Numerous techniques can be used for repair depending on the local soft tissue availability and need for reconstructions. Patients with chronic injuries can undergo a trial of splinting, but surgery is required more often than for acute injuries. Now, what about the jersey finger? The jersey finger is not the name of an individual. The jersey finger is the shirt of the athlete, the shirt, القميص. When you're playing football and the individual is following another competent, he catches the shirt from behind. And usually it is the ring finger which is most involved. So what happens? The flexor digitorum profundus tendon to that finger could rupture with a fragment or not of bone, and this can displace proximally. As a result, the player comes to you and he tells you, I cannot flex my finger. And usually it is the ring finger. Look at what happened. He caught the shirt of his friend while playing football to prevent him from running forward. So it ruptured. The whole fragment rotated, and the pull of the profundus is pulling it backward or proximally. As a result, they end up unable to flex the DIP joint. And at times, if the fragment is large, you can have a dorsal displacement or dislocation of the distal phalanx. So it's the result of a flexor digitorum profundus, avulsion from its insertion on the distal phalanx. The ring finger is the most commonly involved. Physical examination reveals inability to flex the DIP joint or the distal interphalangeal joint. Ultrasonography can help assess the level of the tendon retraction in a timely fashion, although MRI also has good results if performed soon enough post-injury. So you have to keep this in mind. You should aim at diagnosing this early. The Leddy classification is based on the level of retraction. Type 1 injuries, the flexor digitorum profundus is retracted to the palm and the vincula is compromised. And this will interfere with the blood supply of that fragment. The vinculae are compromised. Can I take a 1-minute break because I have to answer an urgent phone? قالوا نعم. Hurry up, please. شو بدك لأن عم بعطي محاضرة. Please كمل. شو بدك؟ إيه نعم عجلوا. إيه نعم. يا الله. أعطيني يلا يلا please. Hurry up. I'm sorry عجل. إيه أصعد عجل أصعد بعطي. إيه شو بدك؟ نعم. لا 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 غالي كثير. هيدي بتاخذ ربع ساعة ولا اوكي يا شباب. طيب اوكي طيب شو البرنامج؟ واجرتي فيها هيدي؟ لا هي عمل طيب اوكي thank you very much. Bye. I'm sorry I had to settle this problem. The Leddy classification is based on the level of retraction. Type 1 injuries, the flexor digitorum profundus is retracted to the palm and the vincular blood supply is compromised. So type 1 is severe avulsion. The tendon retracts into the palm, blood supply is severely compromised. Why? Because the vinculae are interfered with. Type 2, the tendon retracts but remains at the A3 pulley, the proximal interphalangeal joint. Type 3, the avulsion includes a bony fragment. Both tendon and fracture fragment remain at the A4 pulley. And type 4 is a rare injury defined by the presence of both a fracture and a tendon avulsion from the bony fragment. The tendon can retract into the palm. This shows you all the types of pulleys and where the fragment can be stopped or how far this fragment can go to reach the palm. You have to keep in mind that the vinculae through which the blood supply comes to the tendon or to the bony fragment is interfered with. The earlier treatment treat this patient, the better it is. The later you treat them, the results are not very good. So what happens? You have hyperextension, the finger gets bent backward too far and causes the flexor tendon to stretch. It causes a tear in this tendon. And as a result, this can be retracted proximally. If you have a fragment of bone, this can be caught by the A3 pulley because this fragment won't pass. And on the other hand, you can have retraction of the profundus tendon way into the palm. At times, I've treated or dealt with a few of these cases, and it was really hectic in those patients where the profundus tendon retracted into the palm. So keep this in mind. You should know the approaches. You should know how to get the tendon back to its place to treat these injuries. Primary, early, I repeat, primary, early repair within 10 days is warranted. Type 2 injuries involve a tendon that is retracted, but still in the flexor sheath at the level of the A2 pulley. Surgical repair is warranted and should be performed in a timely fashion, usually within 4 weeks. Type 3 injuries include a bone fragment that is caught on the A4 pulley. Open reduction and internal fixation is performed on the fragment that involves the tendon insertion. Type 3A injuries are less common and involve a bone fragment and tendon retraction to the palm. Open reduction and internal fixation is performed as well as tendon repair and should be done within 10 days, as in the type 1 injuries. This shows you another form of injury. The tendon is intact. The profundus tendon here is intact. But what has happened is that the pulley can rupture. instead of the tendon avulsing from the distal phalanx. This is a pulley rupture. And you see that this, the whole tendon is directly subcutaneous. Flexor tendon pulley requires ruptures occur when a sudden extension force is generated on a flexed finger. This is most commonly seen in rock climbers and when they slip, and frequently affects the ring and middle finger. تقشع واحد عم بعربش على حيط. Suddenly he slips, he wants to grab. He grabs his hands on a protruding rock. But all the force is on the pulley. So the pulley can rupture. So it happens in mountain climbers. Don't forget this. The pulley ruptures. Instead of the tendon avulsing, as occurs with a jersey finger, you have a rupture of the pulley in these athletes. Look at it. Look at it. This patient was climbing on a mountain, a steep mountain, and he slipped. He grabbed the stone wherever he could, and the forces were applied between the tendon and the pulley, and this ruptured. So whenever you see this, don't say that this is a debutant's injury. This is not a debutant's injury. This is not a fibrous tissue disease condition, but this is a avulsion of the pulley. Keep this in mind. The patient will have acute pain over the flexor tendon. On examination, bowstringing may be visible if the A2 or A4 pulleys are involved, and the patient will have difficulty making a fist or full fist. Dynamic ultrasonography and MRI are useful in the diagnosis. Single pulley ruptures should be immobilized for 10 to 14 days, followed by therapy for motion and taping or rings to support the pulley. Multiple ruptured pulleys should be treated surgically. Repair can be performed with extensor retinaculum sutured to the remnant of the pulleys. If no pulley edges remain for suturing, a triple loop repair is performed using tendon autograft. Return to sport is permitted at 6 to 8 weeks with continued pulley protection. This is a photograph which demonstrates an A2 pulley reconstruction with a triple looped tendon graft. Full sports participation begins at 3 months. Taping or pulley ring use should be continued for at least 6 months. What about scaphoid fractures? I will be talking about scaphoid fractures in relation to sports injury, not in relation to fractures or trauma. So it won't be in full detail. Keep this in mind, please. Scaphoid fractures are a common problem encountered by the orthopedic hand surgeons. A high index of suspicion is necessary to make the diagnosis because radiographs are often negative at initial presentation. Any history of wrist trauma and tenderness should increase suspicion. On physical examination, tenderness over the anatomic snuff box. You have to know what anatomic snuff box allows the surgeon to suspect a scaphoid fracture. This is the anatomic snuff box. You see, on one side, you have the abductor pollicis, longus, and extensor pollicis brevis. On the other side, you have the extensor pollicis longus. The base consists of the extensor carpi, radialis, brevis, and longus. This is the anatomical snuff box. Why? Because the scaphoid lies behind this. And if you apply pressure, the patient will have pain. If you apply a retrograde force on the distal thumb proximally, they will have pain. If you, on the volar side, you apply tenderness or pressure on the tubercle of the scaphoid, they will have pain. Resisted pronation also elicits pain on examination. A scaphoid view should be obtained with the wrist in 30 degrees of extension and 20 degrees of ulnar deviation. So 30 degrees of extension and 20 degrees of ulnar deviation. This is the position that we like to take. The X-ray. And this is how the X-ray will become apparent. MRI is useful if radiographs are inconclusive. This can allow earlier return to play if no fracture is identified. MRI is used to assess osteonecrosis of the proximal pole of the scaphoid, a common complication of these injuries, and can help assess for scapholunate ligament injury, another common cause of radial side wrist pain in the athlete after a fall. Scaphoid fractures are often missed injuries. Fractures treated less than 28 days from injury result in a 5% non-union rate. If treatment is delayed longer than 23 days, the non-union rate increases to 23%. I'm sure you know all these things about fractures, but you have to know that this is a frequent sport injury. It is imperative that the surgeon educate all trainers and other athletic staff about scaphoid fractures. Don't say, I know about fractures, but this is a known sport. The trainer should be aware of them. Any suspected injury should be promptly evaluated and treated. Scaphoid fracture treatment depends on the location and displacement of the fracture, as well as the skills required for the sport and for position. If clinical suspicion is high for fracture, but the radiographs are negative, the athlete should be placed in a short arm thumb spiker. This is what we tell our junior residents, and an MRI should be obtained. And also, if you take an X-ray after 2 weeks, and you can be able to tell more or less the fracture. Let me tell you something. In fractures of the scapula, we like to take multiple oblique views. Why? Because the fracture is not apparent on all views. It can be apparent on one oblique view and on the other at 60 degrees, and one taken at 30 degrees would be negative. So you have to pay attention to this. How you ask for the X-ray is important. What to do in radio imaging is important. When to decide to treat
لا يوجد صوت. لا يوجد صوت.